While Novo Nordisk is sponsoring this panel, the discussion today reflects the individual opinions of the participants. This session is intended to be a holistic conversation around weight management rather than specific medications. If you have any specific questions around their medicines, we encourage you to visit their website.
Well, good afternoon, everyone, and welcome to this session where we'll be discussing GLP-1s and finding a way to share responsibility to access and innovation. I'm Alice Park, Senior Health Correspondent at Time, and it's my pleasure to be moderating this discussion with, to my immediate left, Dr. Angela Fitch, co-founder and Chief Medical Officer at Known Well. Then we have Nigel Morris, Senior Vice President at Novo Nordisk, and Tracy Svenich, who is the Director of Policy Strategy and Alliances at the Obesity Action Coalition. So I think we have a really great mix of perspectives here from, the drug makers to the patient groups who are, the target population, as well as, the clinician side, the doctors who are prescribing it. So there's really no denying that GLP-1s, these new weight loss drugs, are really transforming obesity and obesity management. But as with any new innovation, I think there's a lot of confusion and there's still a lot of hiccups. Trying to understand who these drugs are meant for, who should be prescribing them, when people should be taking them, for how long, all of those questions, how they're covered, still a lot up in the air, and we're still trying to make our way through all of those challenges. So today's discussion is meant to kind of raise some of those issues and figure out ways and things that we know at this point to hopefully guide some of those decisions and be smarter about how these really powerful and transformative medications are being used. So I'd like to start with what seems like a very basic question, but a very important one. And I think these medications, because they are so effective in helping people to lose weight in a way that diet and exercise and previous medications have not been. We're seeing double-digit reductions in weight loss, whereas previous medications have mostly been in the single digits, I think. So. And we know that diet and exercise, even though it's the option that doctors often tell patients the most, can only get you so far. So let's start with that basic question of defining obesity and whether these medications help us to really get to a sharper definition of obesity, because I think that's at the crux of helping doctors decide which patients should be on these medications and also payers to decide for whom they should be reimbursing them. So maybe we can start with you, the doctor, Angela. Tell us how you define obesity and some of the ways that having these medications now available are transforming how even doctors think about obesity.
Yeah, so obesity, if you look at the definition of obesity, you Google the definition of obesity or ask Siri the definition of obesity or whatever. The definition of obesity is a disease. That's the first thing it says. So we have to believe obesity is a disease in which excess body fat, or adiposity, that's the fancy word for excess body fat, is having an adverse effect on your health. Nowhere in that definition did I say anything about what you weigh or what your BMI is, right? I said this is a disease in which your excess adiposity is having an adverse effect on your health. We know, for example, people of Southeast Asian origin of birth genetically have a higher predisposition to metabolic health conditions such as fatty liver disease, diabetes, prediabetes, et cetera, cardiovascular disease, at a lower BMI because they tend to get excess adiposity, especially in the visceral region or the abdominal region, and their BMI may still be 23. But they have excess adiposity that's having an adverse effect on their health. And recently, the Lancet Commission spent many years as a worldwide commission trying to put this on paper. Took them a lot of time, a lot of discussion. But what we have is this idea now that we shouldn't, base it on just a BMI, like a body mass index, which is just your height versus your weight. It's just a ratio. We should really be basing it clinically on how is your excess adiposity having an adverse effect on your health. And that's really what we've done as physicians all along. I mean, most well-trained and meaningful physicians recognize that. I think the reason we've mostly prescribed eat less, exercise more is that there hasn't really been anything that worked. So you asked, how is this really transforming what we're doing? Well, we finally have treatment that is actually getting patients not only to that double-digit weight loss, but also improvements in their health. Again, that last word in that definition, right? Adverse effect on your health. Now we're seeing all these significant health improvements from this 10, 15, 20% weight loss versus the average weight loss with lifestyle intervention we've known for years, well studied in lots of randomized clinical trials. The average weight loss with lifestyle intervention, doing an app on your phone or working on your calories with your dietitian and your fitness trainer, whatever that might be, whatever that looks like for you, is 2 to 5%. That is the average. And when you look at that data a little further, how many patients are able to lose 20% of their weight with a lifestyle intervention? It's about 5 to 10% of them. Most patients, if you ask them, if you go out on the street and you say, if you're 250 pounds, how hard is it for you to lose 50 pounds? Can you lose 50 pounds with Weight Watchers? I think most people would probably say, oh yeah, I can do that. People can do that. There's this misperception, but that's 20% of their weight. Only 5 to 10% of people can do that. Right. And when I tell patients this, they're like, wow, I don't think I'm one of the 5 to 10%. I'm like, I know, I'm sorry. Because I've tried that 7 times. I've tried it over and over again for the past 20 years, and it hasn't worked. And that patient has felt like it's their fault that it hasn't worked. Like I did something wrong. Yeah. Like I'm not good enough. Like I didn't do it well enough. And then they're trying it again.
And the healthcare system reinforces that perception, right? And not treating it like a disease, but in treating it like your choice. You're not doing it right.
And imagine if you have obesity, like my co-founder of our clinic, she started our clinic because she felt very stigmatized. She's had obesity since she was 13. And, imagine coming in year after year being told, you just have to do this a little better. And you get on this machine in the office, which is called a scale, and you weigh there, and it tells you, ooh, you're not doing better, you're doing worse. And every year you go in, or every 3 months you go in, it says you're not good enough, you're not doing it good enough. Why are you not doing it good enough? Yeah. And that brings in internalized weight bias. The patient then says, I'm bad, there's something wrong with me. And then we get even worse outcomes from that. So it's a vicious cycle that is all fueled by the fact that fundamentally as a society, we have to really believe it is a complex chronic disease, as complex as cancer or cardiovascular disease or other diseases where we treat them not only with lifestyle intervention, but we treat them with other surgical and pharmacological and other interventions, procedural interventions, to get the best outcome. Not because anybody wants surgery and nobody wants a medication. People say that all the time. I don't want a medication. Well, me either. Who wants a medication today? Who wants to take a medication today? Nobody wants to take a medication. Or who wants to have surgery in the room? None of us do. But I swear, if I said, all of you are getting appendicitis today, who wants surgery? I bet everybody raises their hand, right? Because antibiotics. I know there would be a debate there. I see your MD there. We could debate that. But I mean, the point is that we have diseases that we treat better with medical interventions that we have created thanks to science.
Absolutely.
Right. Nigel, your thoughts on defining obesity as, a maker of a treatment for it.
Yeah.
You start with obesity as a disease.
We do. So I think, so Novo Nordisk has been in the space of obesity for 25 years. And I think that sometimes people look at when a particular medication hits the market and they think that that's when you started. But it actually was 15 years before our first medication was actually, kind of released and available on the market that we started the research around this. So imagine what kind of public perception around the disease of obesity was 25 years ago. It was not considered a disease. So it was certainly a risk, but it was also, I think, a leap of faith. Certainly as we're here at Aspen, when we think about predictive and predictive work and maybe knowing where the problems are going to be, not necessarily where they are at that point in time. So that's one point that I'll make is just kind of the length of time that we've been committed to this space. The second thing that I'll say is that we talked about the Lancet Commission and how the more we know, the more we're developing exactly what this means. I will tell you, BMI charts, according to the BMI chart, I don't know that I've ever not been overweight. I'm 5'3". There's not a lot of space for weight there, and so I think that it has really been progressive to see BMI come out. But the piece that I would add is that now, because 90% of Americans have commercial coverage, it usually comes down to a payer decision in terms of what is the criteria for the medication. And when the PBM or the health plan is trying to determine, okay, first of all, do we even want to cover this, which we know continues to be an issue and one that we're deeply passionate about, because every other disease is covered under a standard listing. You don't have to wonder if there is coverage for a medication to treat your hypertension or your cancer, but you do have to wonder if there is an option for you, because employers have to make that decision and take on that cost kind of at a prescription level. So those are all issues that we're continuing to try to deal with from an access to care perspective. But it's much easier if I'm writing down criteria to come up with a number. And what's a number? A number is usually a BMI. So you'll continue, even though we know that we've progressed the definition of obesity, to see payers very much deciding at what BMI do I feel comfortable paying for this medication, whether it's a BMI of 27 with one comorbidity, or whether it's a BMI of 40 or 45 or 35. It varies depending on the payer. And so there is an area that we have to continue to really focus, because if you think about someone, yourself, a family member, a friend, who finally has actually understood that after all this time and frustration and guilt and anxiety and all of the things that come along with living with overweight or obesity with really next to no treatment, that you're activated and ready to seek treatment, and then you miss that BMI number by 1 point, even though your physician is telling you, listen, I'm seeing kind of the health cascade that's going on, and you are a good candidate for this medication. That is the big opportunity I think that we continue to have as our understanding of obesity grows as a society, to make sure that the treatment options to treat obesity are catching up with that and that they're in line.
But there's so many forces, I think, that are keeping things like BMI and the sort of traditional way of looking at obesity in place, especially if we think about expanding treatment of obesity beyond obesity experts. I mean, I know there's very few obesity specialists, right, even in the United States. So if you're thinking about having primary care doctors and even cardiologists now, internists treating obesity, for them who don't feel expert and comfortable, having a number gives them that comfort and reassurance. So we've got that element too. Tracy, I want to talk to you about, from the patient perspective, this long-standing view of obesity, not as a disease, but as really a lifestyle choice and something that is, the burden falls completely on the patient.
Yeah, no, thank you. So the Obesity Action Coalition, we are the patient advocacy group. We serve people living with the disease of obesity, and we do that through raising awareness about obesity as a disease, providing support to our community, educating our community, as well as advocating for our community. And from a definitional perspective, to patients, obesity is when, no matter what your weight is, it's when you get sick with it, or when you don't have full body functioning, or when your quality of life is impacted. So it's not all health outcome driven, but it's a major part to it. So we take a little bit of a broader definitional approach. And I think the topic of weight bias and stigma has come up. Really quick, I'm going to put on my Georgetown professor hat. Weight bias are negative attitudes and beliefs that we all hold. It is inherent in our society, is inherent around the world. But then weight stigma is how those are expressed, how we see them come out in the world, whether it's through negative comments, images, language, entertainment, health insurance coverage policies. So that is, I think, a key driver and a thread for all of the other barriers to care and respect and compassion that our community faces. So, this work of the Lancet Commission was raised. We see that as a tremendous step forward, that all of these experts and stakeholders were willing to come together and have this discussion about, one of these first very large convenings on what is obesity, what are the approaches we should be taking, and my organization was a part of that, and we see that as a very positive sign to continuing the discussion among many medical societies in the U.S. and around the world, to getting to a place where when someone living with obesity, again, no matter what their weight is, where it's affecting their health, their function, their quality of life, can say, today is the day I want to find a healthcare provider that can help me. And when they go to that healthcare provider knows what to do, knows how to help them, and the patient receives respect and compassion and dignity, and has treatments available and a care plan, and they're covered, and it's not going to cost them a fortune. Where today, most people are left on their own to figure out where to go, how to get help, if they can find someone to help them, then is it covered? Is it affordable? Not all coverage is affordable. You might have coverage in your insurance, but you might not be able to afford it. So many things at play, but I think the weight bias and stigma that is just inherent is a key driver of all the barriers.
Absolutely.
Yet it's the largest chronic disease in our country.
Yeah.
And it's not covered as a standard benefit like other chronic diseases. And it leads to so many other chronic diseases
Right.
and so many other
Over 60,
decrease in
yeah.
quality of life.
Yeah.
You know, my mother is currently essentially dying of fatty liver disease. And, had she gotten care for that, right? She has cirrhosis now and has been in the hospital multiple times. And, it's sad that despite the fact that her daughter for 20 years has been in the obesity treatment space trying to encourage her to go on treatment, meaning even in our own families, we have stories where, we can't even help our own family. And a lot of that was around her, being concerned that it wouldn't be covered, that it would be too costly, that it would, some unrealistic concerns around side effects and other types of things. There are side effects, but you don't know until you try if you have those side effects or not. And you should have a relationship with a clinician that knows how to manage those. They're really not. We've been prescribing these medications, GLP-1s, for 20 years. We've had them on the market for 20 years now. They're not like brand new medications. The newer ones are more effective, so we do get greater efficacy with the newer medications.
And they've been for diabetes
Exactly.
and only recently
for diabetes,
obesity, right?
Well, 10 years
10
ago
years
for obesity. So, I mean, it's not like, but they say it takes 20 years, unfortunately, for things to become normalized within medical care delivery, which is, I think, unfortunate. I personally think we should innovate. We need to innovate faster, but also within the respectful guidelines of developing care plans that are evidence-based and delivered in a comprehensive way.
So where do we start with that? And I think one of the questions would be, as Tracy was raising, like, where do people even go, right? Like, who should be prescribing these medications? Angela, in your view, should it be an obesity specialist, someone with a background in obesity care? Can it be a cardiologist, because it now reduces heart disease risk by 20%, an internist, or GP who people go to every day or more regularly every
so we
year?
are very passionate. So I am the past president of the Obesity Medicine Association. We are as Tracy is talking about the Obesity Action Coalition, the patient advocacy arm. We are the clinician advocacy arm, or the Clinician Professional Association. The Obesity Medicine Association celebrated its 75th year this year. We are 75 years old. We had enough discussion of obesity 75 years ago that we put together an association of clinicians. Now, granted, I remember going to meetings even 20 years ago, and there were like 100 of us there. And now we have 1,300 people at our meetings. So 1,300 clinicians, these are dietitians, psychologists, nurse practitioners, internal medicine, cardiologists, coming to our meetings to learn about how to treat obesity. One of our mission is to improve the education of clinicians on the disease of obesity. We have a library that clinicians can get CME and lots of other, continuing medical education. So we firmly believe that obesity needs to become a disease treated in the chronic care model within the patient-centered medical home. And I think there are different models of delivering that, but it has to be delivered in a chronic disease fashion because it is a chronic disease. So it's not something but what we've done is as you mentioned, Miguel, and Tracy, you mentioned, you just go out and find it on your own, because we've said, go here to Jenny Craig, go here to Weight Watchers, go here. We've made it a patient thing to do, right, in a very segmentalized and commercialized fashion that has a billion-dollar market around it itself, right? And that's where I think we need to transition that and bring it into the medical home, because we only have something like 8,000 certified obesity specialists in the country.
And two-thirds of the population is overweight or obese.
One time I calculated, back when we were at about 5,000, I calculated that number that we would each have 32,000 patient panel. And normally a doctor has about a 2,000 patient panel and maybe a 3,000. I had a 3,500 patient panel at one point in my career. I can't tell you that was, the best thing. But the point is that, for my own mental health and work-life balance, But again, the idea is that we have to expand access to care, but we also need to make sure there are some guardrails, because right now, unfortunately, we've swung the pendulum in a different direction, where unfortunately people are also getting access to some of these medications in a manner in which they're filling out a form and sending it into the internet, and the internet is giving them medication. And so again, we need to make sure that that's not happening, because we firmly believe as an association that we need it to be a more comprehensive, chronic disease-based approach that is, now that doesn't mean it's not delivered via telehealth, don't get me wrong, because I run a clinic where 80% of our care is delivered via telemedicine, but we do have in-person clinics as well, and 40% of our patients have never been seen in person. So the vast majority of our patients are seen in person at least one time, or more yearly sort of thing, for ongoing care. But the point is that we need to make sure we develop comprehensive care guidelines, and that's what we're doing right now. We're developing the standards of care for obesity treatment clinically at the ADA, American Diabetes Association, along with the Obesity Medicine Association, the Obesity Society, and these are some of and the OAC is part of that standards of care as well. So. Yeah.
Maybe to offer a little bit, so just like the disease of obesity, the ecosystem in treating obesity is complex. And we at Novo Nordisk have, as our North Star is always the patient. And how do we get the proper medicine or choice of medicine to a patient? And it's been fascinating, especially I would say in the last 3 years, to watch how this space has developed. So, on the positive side, there is more awareness of obesity as a disease than ever before. But on the challenge side, stigma and bias in the healthcare system continues. We know that there are over 100 million people living in America with obesity, and right now, with all of the medications that are on the market, about 3 million of them are being treated. Part of that is absolutely because of access, coverage, cost, those sorts of things, but part of it is also because people are still out there struggling with the misinformation on TikTok, or on the notification that comes up on your phone. What we have realized, and what I will tell you, my story personally has been, this is not me as Novo Nordisk, but me as a patient, as a person who has struggled with the disease of overweight. There is no thing that I know in society that is more polarizing and more activating than the need to lose weight. So activating that we've seen people willing to inject their bodies with an unknown substance from an unknown origin in a vial and syringe because they believe that that is a hope that they have to lose weight. And so as we scan the market, as we look at some of these, what we call consumer trends, what we've had to decide as we've evolved over the past 10 years is that the most important thing, especially in a post-compounding world that we're in today, is to make sure that we are going where the patients are. That doesn't mean that every single time or every single platform, especially if you're talking about telehealth, is going to be ideal, but we are continuing to be committed to working around comprehensive care and using the influence that we have as a stakeholder in the market to do that. And so it's fascinating to talk to family members, to talk to friends who have gone to telehealth, many of them spending more money on compounded medication than they would actually spend on FDA-approved medication because they don't know. And that is, I think, the accountability that we have as a manufacturer, that we have as an ecosystem to make sure that we continue that education and that we continue to look at how do we continue to educate more physicians. There's more physicians prescribing anti-obesity medications today than ever before. There's an interest there. How do we actually that's why you have more people coming to even the OMA meetings. How do we take advantage of that interest, that leaning in, to make sure that the proper education is there, that the proper standards of care are there?
And Tracy, how do you talk to patients and advise them about how to make that distinction. You know, how do they know that they're going to a legitimate site or that they're going to get a legitimate product, or when they're more than likely to get something that is not legitimate?
So we have over about 90,000 members in our community today, and you know, GLP-1s in general have literally changed lives and saved lives of our community members. They have brought hope to our community, where there have not been safe and effective treatment options for until now, really, until the last few years. So this is really, I mean, the term has been used many times. It is game changing. I hear from folks every single day about it. My husband lives with obesity too. So let me quickly take you on a patient journey. This is what I hear from folks every day. So, you know, someone says, I know I'm living with obesity. I want to improve my health. I want to improve my life. And, you know, help me find a provider. We can do that. Help me, OAC, we advocate for obviously addressing weight bias and stigma, but we also do a lot of advocacy around access to care. What does access to care look like? It is the wild, wild west or a wildfire today. And what happens is, you know, we then walk the patient through, well, what kind of health insurance do you have? Do you have coverage? And then someone might have coverage, but it might be, and again, I'm talking about pharmacotherapy in particular in this instance, but the copay or the coinsurance might be unaffordable, right? A copay or a coinsurance of $700 is not coverage to our organization. So we try to, you know, assist patients and individuals in that way. And then, you know, for those that haven't found us, for those that haven't found a healthcare provider that knows how to help them, you're on your own, right? So you're Googling, you're asking your friends, you're asking your family members. Sometimes you find, and the landscape and variety of what's available on just by internet searches is also quite as a wide range to that too, right? Some are more reputable offerings. Some can, you know, find a known well clinic and get you connected to an evidence-based telehealth program. And then sometimes you can just order something from China and, you know, and pay for it. So we direct our community to evidence-based options through qualified healthcare providers. And we have put out many public statements about the concerns over this side market that popped up due to the shortages over the last couple of years, that we can't say what's safe. We can't say where you're going or what you're getting is what it says it is safe to take, what the side effects will be, if the dosing is correct, if you'll have long-term complications. We have no idea. So that is a large part of our advocacy in this illicit manufacturing space. Compounding is a valuable service. When you have, compounding is for individual need, right? If you have an allergy, you can't take one of the branded manufactured products, that is the appropriate option for you. Mass production of compounded products was acceptable during the shortage period. It is no longer acceptable. That time is done. These practices continue, and OAC, we have been engaging with the FDA on this issue and what it means to our community. We have reached out to the compounding associations and talked to them. We've talked to members of Congress about the concerns. We've talked to the National State Boards of Pharmacy, right? Because we've got some federal jurisdiction, you've got some state jurisdiction. We've talked to everyone and expressed the concerns that we have for our community, because if you are diagnosed with cancer, you're not told to go find your chemotherapy online, right? There's a provider that knows how to care for you, give you treatment options, give you a care plan, and you have coverage. That's our aspiration.
I think that's a very good analogy, and one of the reasons why we see this Wild West, and particularly with the compounding, first of all, is the confusion, right? That it is allowed for certain groups, if you have allergies to whatever ingredients are in the medication, that a pharmacist can make up something specifically for you. But it's also allowed during shortages, when, you know, manufacturers are not able to provide enough to meet the demand. So, and that, as you said, is now over. But Nigel, I want you to address the question which you must get a lot, which is the cost. Because a lot of people say they turn to the compounding. Often it's cheaper, sometimes it's not, as you're saying, Tracy. particularly they turn online because it is cheaper.
Right.
And yes, sometimes too good to be true, but yet that is the driver, right? You've got someone, as Tracy's saying, who's motivated, who's got that intention, and they want to address their weight, and they go online, they find something that's cheaper, and they're like, so I'm going to do it. So what can companies do to address the cost? Because it is still too high for a lot of people, with and without coverage.
Absolutely it is, and I think it's something that is multifactorial. And there's really, I think, 3 areas that Novo Nordisk has focused, and I think this is a focus of the industry. And I'll just stop and say, the more manufacturers want to enter this space, the more just information is out there, the more resourcing, the more innovation. So it's really a good thing. I think that there's more and more stakeholders coming to the table to make this. So we started with coverage. As I said earlier, 90% of Americans are covered by commercial insurance. And most of the time you don't think about it because you have a preferred medication. Hopefully the one that you want or that your doctor prescribes is on your formulary, and you go to the pharmacy and you pay $25 or $10 or no money, depending on what it is. If it's generic, maybe it's $3. The point is, because anti-obesity medications are not covered, that's why we have the complexity and the layers that we have. So we are deeply committed to continue to work with payers and work throughout whether it's policy, whether it's with the payers themselves, to expand coverage to medications. Because to the extent that they're covered on standard listing, and we know this from certain areas, Boston, Massachusetts being one, North Carolina historically being another, where large plans, Blue Cross Blue Shield, state health plans, Medicaids, have covered these medications on standard listing. And the way that they're prescribed in those ecosystems is completely different. So we know that this would be a lot less complex if we had that coverage. We're not going to stop doing that. There's right now about 55 million Americans that have coverage through commercial insurance. That changes. Sometimes you have it this year, your payer decides they're not going to cover it next year. Sometimes it's vice versa. So we have a lot of work to do there. So that's one piece. We recognize that while that fight is going on, because it's been 10 years and we've really moved the needle, but there's a lot of work left to do, that we also have to look at cash options. Within the healthcare system, some would say the broken healthcare system that we have in America. And so you'll see over time these medication costs go down, especially in a situation where finally we have supply, which is wonderful news and something that we're very, very happy about. So we are definitely looking at what the cost is, and without talking about medications, that cost can be $4.99 for a cash pay patient, which is still very restrictive. I don't want to stand up here and say that that is something that everyone can afford, but certainly less than it was from a cash perspective before. And of course, lots of programs that manufacturers come up with to continue to help with that, to lower that cost, even more. But $4.99 versus as little as $0 and as much as $25 if you have coverage are in 2 completely different categories. And then last, there's something that I'm deeply passionate about, which is communities of need and where we have the highest medical need. So Medicaid, Medicare. These are areas of coverage that we are continuing to work. Now, on the Medicaid side, we've gotten a lot of work done, and there are several states that are covering anti-obesity medications now, and we're really happy about that because we know that in areas of most need, they absolutely can get access to that medication. But once again, there's more work to do. And
Massachusetts.
Yes, we still have to work there. So in Medicare, we've been working for a really long time on something called the Treat to Reduce Obesity Act, which is something that everyone within the obesity community is definitely lobbying for. We were close at the end of last year, but you know that there's a change in administration, and there's all kinds of political things that get in the way of that sometimes. And so policy making is really important, and making sure that we're activating policymakers is going to continue to be important. Fortunately today, because there are other indications for these medications. So when you go back to the original definition and we talk about the fact that obesity is actually affecting your health, we're continuing to study what are some of the other diseases, that cascade of diseases, over 60 of them, that start with an origin of obesity. So things like cardiovascular health, stroke, heart attack, very much important. And so you'll see indications and data around that. Chronic kidney disease, liver disease like MASH, which Angela was just talking about in terms of fatty liver. So as data comes more, OSA is another one, obstructive sleep apnea. So there are different medications and options on the market today where there are these secondary indications, and so people can actually access it through Medicare. But we still have so much work to do. And I mean, just there, you see the complexity that we're dealing with.
Which I
because
think
there's
we
so much.
all need to stand up for each other and stand up for, we're talking here at Aspen, it's about big ideas, I think, and this is my first time, so thank you for inviting me. It's very nice, I love it. I'm definitely gonna come back so I can be here the whole time. I've said for a couple years that, I don't know, this is my big idea, but you guys can take it if you want. We need a public health emergency, because this really is a public health emergency. We have 140 million people, if you include the people with overweight and a comorbidity, but hundreds of millions of Americans that have a disease that is marginalized, stigmatized, and uncovered and untreated. We finally have treatment that prevents people from having a heart attack and stroke if they've had one before, that improves kidney function, that prevents them from ultimately potentially dying of fatty liver disease. All these different other things that we have, and we're sitting here pointing fingers at each other saying, well, it's because of you it's too expensive, and they're like, because of you it's too expensive. And if we just sat down at a table and tried to figure out, how can we solve this problem rationally, maybe we could do it like we did with COVID. I'm not saying we did it rationally with COVID, but I mean, the point is we said it's a public health emergency. We're going to come together. We're going to figure out what the solutions are instead of just sitting around waiting for, supply and demand and economics to solve it, I guess, because that's what it feels like as a clinician, at least, and as a patient, that we're sitting around, waiting for economics to solve it. I have patients that say, well, if my insurance even covered it and it was $100 a month, I'd pay for it instead of the $25, right? So again, I think we need to come together, all of us, and say it needs to be a standard benefit. That's ridiculous that it's carved out, that it's up to my employer to decide if it's covered or not. It needs to be a standard benefit. It's a disease, and then it's currently a public health emergency. Let's fix it instead of sitting around and waiting.
But I think delving deeper into that, standard benefit for employers in particular is the fact that there is a misalignment in our country, in our healthcare system, in the people who are incurring the costs, the patients, and those who are paying for them, right? Because it's the employer, or for the bulk of the population, the employer or the federal government, one or the other. And so there's a lack of alignment in terms of understanding incentives and savings and cost effectiveness there. But even beyond that, I think, particularly in the case of employers, you mentioned the economics, but there is no incentive for an employer to pay for several $100s of treatment per month for someone to, lose weight, and then within 2 years get a job somewhere else.
Which is why they all need to do
who
it.
reaps the benefit.
It's a very socialistic view, I realize, but I mean, but we all need treatment. 40% of Americans need treatment, so we need to spread it out, And
or employers need to realize that even if they are losing money on,
one person, they're
one
gonna
person,
gain it on the other
someone
person.
else may
That's what
come
I'm
in
saying.
who someone else
That's
has
what I'm
paid
saying.
for.
So we're caught up in this, well, I'm not covering it because
Right.
she's not covering it, if we're both employers, right? But there's also other creative ways. For example, we can't get coverage at my clinic. We are under 200 employees at the moment, and we've only been going for 2 years, so soon we'll be above 200. But when you're getting insurance, you can't even elect. So Blue Cross Blue Shield Massachusetts, which Nigel mentioned, has been one of the people to have it as a standard benefit, is actually taking it off as a standard benefit as of January. I'm not actually sure it's even legal in Massachusetts, but that's a whole other question that I'm trying to work on. But the point is that it's taking it off standard benefit and making employers pay extra for it. But in doing so, if you have under 200 employees, it's not even an option.
Right.
So we can't even get it anymore. So we've created a separate benefit in a separate category in order to cover our employees in the cash market.
Right.
So I think there are other creative ways, is my point, to solve this problem. Even if it's a government solution. I'm not, but I actually think could be a government solution. If the government paid $500 a month for people with obesity to get the benefits, as a clinician, I think that would do more for our economy and our society. I had a patient, he was on Medicaid, so he had coverage. He was disabled, a younger patient who was disabled with a family of 3 children. He was very devoted to serving his children. His wife had died. He was a single father, and he was on Medicaid. He got treatment for his obesity. He got better. His back pain was better. His disability went away. His disability was really complicated by his obesity, right? And he decided to get a job. Not the right answer for him, actually, because then he lost coverage for his obesity treatment, because he got a job and went back to work in the United States of America to be a productive citizen.
Yeah.
How can we do this in 2025? Like, we are the United States of America. I think we should be able to not have that happen, you know? And that's what we are having happen today. It's really happening.
Yeah, it is. And I think, it can be overwhelming sometimes when you think about all of these different scenarios and why we are where we are. I think the important thing, and I really believe this, is that incremental change in what we call micro ecosystems, that means each of us doing our part, moves the needle a bit. And I've seen that happen over 10 years, and I know that there are more patients who are getting treatment today. There is a greater awareness of obesity as a disease. The work is not done, but incremental change happens, and over time, that's where you see societal change. So I think
It
it's
has
just,
happened hugely, right? I mean,
has.
it's happened hugely, and so I don't want to downplay that at all. So I'm
But
grateful
it's-
for that.
but it's
I
very
want it to be faster.
yeah.
Well, I think one thing is clear is that these medications, because they are so powerful and because they're in such demand, right, from the patient population, that they've really exposed a lot of the failings of our healthcare system and kind of the misalignment of incentives,
Yeah.
like you were just saying, Angela, and clearly we have a long way to go. I want to take this opportunity to open up the session to questions from the audience, and it looks like we've got quite a few. So let's start there.
From a diagnostic perspective, it strikes me counterintuitive to say you're only obese when you're experiencing health problems from the obesity. It's sort of like saying you only have an alcohol problem when you start getting 2 or 3, DUIs. That's way down the track to numerous health problems. So I think we have to define this upstream a little bit better.
Yeah, and we actually take into, I said adverse effects on your health, but we actually, as clinicians, include in your health your mental health and your, as Tracy mentioned, your physical functioning, right? So your, for our children with obesity, it could be bullying at school and that sort of, so it's not just, to your alcohol point, like if you're getting DUIs, I would say that's having an adverse effect on your health, right? Your alcohol use, because something bad has happened to you because of it, right? So it doesn't have to be, I guess it doesn't have to be a health problem like high blood pressure, or I think we have to think broader about and maybe we call it a physical problem or something where it's impacting you. We want to say that because there are people with obesity and excess adiposity where they might not feel it's an issue with impairing their physical functioning or impairing their health, because we do know there can be small populations of people genetically that where their excess adiposity isn't as strongly affecting them from a risk of mortality or risk of having something happen to them, right? So we also have to respect their desire to also live in a larger body and not be stigmatized by that. Right. Because of some of the stigma and bias that we're talking about, that's created this idea that that everybody with obesity should lose weight. And that's what we definitely, as clinicians, there's also the idea that certainly if you have obesity today and it's not affecting you, it likely is going to affect you maybe, at some point in the future. And so again, we still try to educate patients about that. So that's the idea of, preventing diabetes or preventing something from happening, osteoarthritis and other diseases that happen due to the, excess physical forces of your body weight, right? That might not be affecting you today, but down the road might mean you need a knee transplant at 40 instead of 60, right? So again, we do have to think about, I totally agree with you, we don't want it to be just about health, but we want it to be a broad health, like sort of overall, I guess.
Yep, for sure.
Okay. Let's do one on this side. Is there a mic? Right there, yeah.
Hi, my name is Brody. I'm a cardiology fellow at Brigham and Women's Hospital in Boston. So I couldn't be more, enthused about the cardiometabolic advantages of being on GLP-1. But whenever there's a number, people can fall below that number. So what is your thought about when people do fall below that number? Should coverage be continued because of the other benefits? And what is the insurance perspective of that?
Actually, if insurance today, at least, if insurance opts in, so if your employer opts into obesity coverage and decides that obesity is a worthy disease that they're going to cover for you, then typically then you have coverage for both weight loss and weight maintenance, because the package insert says this drug is approved for weight loss, but also for chronic weight maintenance, because the studies have shown over and over again, when people come off of treatment, the weight comes back on. And that's not because they didn't learn how to behave when they were on the treatment. It's because what we know about obesity is even when you have obesity, that what I mentioned earlier, that lifestyle change alone is oftentimes, most of the time actually, not enough to treat your disease, because the disease is the underlying problem. And so again, for most patients, as long as they are on it, as long as they have coverage, some employers just drop coverage randomly altogether from everybody. And so again, it's not, patients will say, I lost coverage because my BMI went down, below a certain criteria, but that's not actually the case, because we have to fill out the prior authorization correctly. If you're not filling it, if your staff's not filling it out correctly, that's usually the problem.
Which goes to kind of education for HCPs who have not had to do this before, and also payers who change criteria often. So it's really important that when you are filling out what we call recertification, so usually a payer will cover a medication for a period of time, and then they'll ask for documentation that you have to resubmit for that. It's important to talk about what you started at. Whether that's A1C for diabetes patients, or whether that is BMI or whatever the criteria is, and make sure that it's very clear that you're taking it for maintenance. That's why we call them anti-obesity medications instead of weight loss medications.
We hate weight loss drugs. Yeah. Or, are you ready for this? A large media, shall be not unnamed media person,
not
media
time.
channel, not time. But I did a recent segment, and underneath my patient name, it said weight loss drug user.
Wow.
That's how they,
described you.
It was Dr. Angela Fitch, co-founder, chief medical officer, right under me, right? On the, what is it called, the byline, on the TV screen, where underneath it says the little thing. And I was just like, oh, we have such a long way to go. We shouldn't be weight loss drug users, right? I mean,
questions. Yeah.
That's not good.
Not at all.
All right, we'll switch over to this side, right there.
I don't remember which one of you mentioned this. I'm also very concerned about underserved communities that don't have access. They don't have health care. They don't have the money to buy the medications, and they are suffering to death.
Yes.
And so I don't know if any of you can offer a word here.
I would love to, yeah. So I think what I really want to stress is that solving for the obesity and overweight issue in America is multifactorial, and it's going to take all kind of community stakeholders together to do that. So yes, we're talking about GLP-1 therapy. That's what we're here doing on the panel, but it's also really important to talk about the work that we're doing, for example, around food deserts, around nutrition, around education, and working within communities with partners who are already embedded in that community, who understand what the issues of that community are. It could be how far you have to travel to get to a supermarket to even get produce. It could be, cultural issues that have to do with, okay, the food is here, the produce is here, but guess what? We're not going to eat that because that's not what we're used to eating. So yes, it's about access, and we'll continue to do that in terms of having medications as an option, but we have to actually treat the whole kind of, I'm a social worker by training, so this is all about kind of pulling that community together to solve for some of these social determinants of care and the inequity that we see in certain communities. And that's something that we're deeply accountable for and committed to.
And I'd just add, from a policy perspective, Medicaid coverage and access to care for all evidence-based interventions, so that includes nutrition, behavioral interventions, pharmacotherapy, and surgical interventions, are a focus for many in the advocacy community. Right now, 14 states have some level of coverage, but we have a long way to go.
Okay, let's see, right here in the middle on this side. Trying to go from both sides.
Hi, again, thank you for a very enlightening conversation. Now, with the medications have a lot of promise, but what happens when they don't work, and how often doesn't it work?
So, with our current medications, right, I mentioned that with the advent of our more what we call highly effective GLP-1 medications, our newer round of GLP-1 medications, now we're getting about 40 to 60% of people into that 20% weight loss category. We have, with our medications, still though about 10% of people, maybe upwards of 15% of people that are what you would call non-responders. So they don't lose 5% of their weight, right? And so there is still a need. That's what Nigel mentioned about, there are more than 120 different drugs in the pipeline around this class, around the disease of obesity. So there is many, many more innovations happening to try to address that. Because when we say obesity in the medical community, we actually call it obesities with an S, because it's kind of like if we had cancer and we only had one chemotherapy or two chemotherapies, right? We probably had a day when we had that, right? Back in the day, and we gave everybody, we gave lung cancer and this cancer all the same chemotherapy, and we got a little bit of benefit probably, but not, the benefit we have today, because we've precision medicine and we've researched if you have ovarian cancer, you should get this protocol because it works better, right? And so we're going to get there with obesity, but we're a ways away. And a lot of that is because of the stigma and bias that we talked about before, because there hasn't been as much investment in this as a disease as, like I said, Novo Nordisk and others have put years of investment into this to really sort of bring us to where we are today, and we have a long way to go.
And I would just quickly add, those non-responder patients may be candidates for surgical interventions too. So
so that's what we end up doing. We would try other medications, because right now it's a trial and error type of thing, and then surgery is really still bariatric surgery is the most effective treatment we have for the disease of obesity, and for a lot of patients, if they get to that situation where they are a non-responder, that's what we discuss.
All right. And unfortunately, we are at time, so I don't want to keep you from your next session, but I want to thank Angela, Nigel, and Tracy. Thank you very much.